Good morning. It's my great pleasure to be here to present and share our clinical experience towards tattooless and markerless sgrt for multiple treatment sites. Okay, out here. So at Memorial, we're committed to using sgrt for clinical treatment. So by the end of the year, we're going to have 26 LRT advanced system and 2 LRT inboard system. At Memorial, we have a uniform clinical procedure across all 8 clinical centers. So therefore, we need a very well-established procedure to proceed for sgrt treatment. We started tattooless sgrt last year. This is most likely to delayed due to the pandemic. So, to manage all this complexity and then the clinical workflow, we created the sgrt physics team and also RTD champion team. So on the physics side, we have a biweekly clinical research meeting to discuss about what we will do in the future, and then we also have biweekly clinical meeting to cover the clinical issues, including troubleshooting and so on. And then we work closely with RTT to get the clinical procedure going, and then also provide periodical in-service to make sure the clinical procedure is executed as the way it is supposed to be. And then also we work closely with the Vision RT just to, because we have probably the largest institution with many of their systems. So for example, we have achieved a 1 weekend upgrade for all system we have last year. Here is what we're going to talk about today. First, I will discuss some background. I know every audience probably already know why we proceed for tattooless. And I will focus on 2 clinical sites for tattooless sgrt. One is the breast. In breast, we have 2 treatments, and currently we use tattooless. One is PBI, the other is whole breast with a locally advanced disease. The second one is hypofracture brain, SRS or SBRT. So lastly, I will just bring some issue about the future challenge in this field. Okay, so tattooless demands mostly initiated from patient. They don't like to be marked in any way. See here, you can clearly see the marks on the patient's skin. And then currently there's 3 optical surface imaging system available. So we did some survey about all these available commercial products, and then LRT certainly is the best as from our point of view. So the patient setup have gone through the conventional tattoo laser-based setup since the beginning of the radiation therapy. And then recently we see more and more study to show and then compare the difference between conventional setup and then sgrt setup. And then in the last part, oops. Yeah. In the last chart is the currently we proceed using only sgrt without tattoo. Obviously, the second part is has contained some redundancy, so you do both, and then certainly once we establish the the accuracy of the sgrt without tattoo, and then we certainly can get rid of this conventional setup. One more important thing is sgrt is not the same as IGRT, as you all know. So therefore, if you migrate from a conventional setup to tattooless, whatever you do for patient setup using IGRT, nothing should be changed, no more, no less. So patient setup works, especially for tattooless, we still need to go through all phases of clinical practice through simulation planning and treatment. Same thing apply to tattooless. And then at MSK, we proceed this tattooless SGRT treatment very cautiously with IGRT confirmation. So that means all the procedure we're doing has IGRT required for patient final setup. So SGRT will be the pre-setup, but we will show the benefit of that. So first of all, there's no skin markers, and then the BB is still required at planning part, so we can set up our ISO center. And also, one of the benefit is in the setup instruction, it's very simple. You don't need to show the patient chart or graph, anything in that nature. So lastly, yeah, so also we have a way to show other complicated procedure, including the bolus placement. So first, the PBI procedure. So their studies, here at least only 3. So there are many of them. So basically, they all compare the accuracy between the conventional setup and then SGRT setup, and then using different way to look at the differences. Most people using the 2 cohort patient, so you can compare across the two groups. And then second approach is, keep hitting the wrong button. Second approach is consecutively. So you're using conventional setup, you're using SGRT setup, and then finally you're using, in this case, using CT on rail. And then we did this study as well. So the way we do it is we have a patient pool, and then we alternatively using tattoo setup and then tattooless setup. So continuously, alternatively throughout the treatment. So therefore, for the same patient group, we have both data. So we consider this is a fair comparison. And then the conclusion we got from this study is, first of all, the accuracy is similar or many times better, slightly better than the conventional setup. And the most advantage is the time saving throughout the setup process. Our study is very much consistent with other people's results. And then you can see in this chart that on the average is similar, however, the variation is much reduced. And so this is one of the benefits. So you would get more consistent results through tattooless SGRT setup. This is one of the examples for our setup instruction. So now this, the chart is gone. And then, of course, we don't have a tattoo. We still place the wire, this is because it's clinical needs. And then in this chart, we also have a backup strategy, just in case LRT is down. So we use nipple as the natural landmarks of the patient, and then just do pre-setup. If the patient is not available, so then we were using the scar lateral side as an initial point to align the patient. And then because this procedure are all come with the sgrt, so the final setup will be using X-ray. Yes, we have been using LRT for many years, since I think earliest days 2010. And then we developed the frameless sgrt and also start using LRT for two-step patient setup, meaning we align the patient arm and chin first, and then focus on the ROI. So the benefit is we can, through this process, we can minimize the breast deformation. So therefore, the setup will be more reproducible. The second thing is we can minimize the change of location of the local lymph nodes. So this, because arm position, especially axillary nodes, so they will be moved with the arm. So you can, here is a LRT posture video. I think this is a very, very good features. I would give this feature the best feature award for the VGRT folks, because we will see that this feature not only useful here, but later on for brain, they're also very unique and very easy to use. Okay. All right. Yeah, so here I'll give you a couple of examples about the deformation. So for instance, here we see there slightly the arm misalignment, and then you can see somewhat breast shape change. Because this is not a large patient. For large patient, you're going to see more. So there's another example for local lymph nodes part. So you can see the arm with a very different position, and then the axillary nodes will be dragged away either medially or laterally in this case. And then another thing is ongoing study where we have been observed the DIBH patient is not always using their chest to breathe. So meaning there are a certain percentage of patients using their belly to breathe. In other words, if we're using chest only, if we're using chest only ROI, then you don't see much rise for the chest. So therefore, you hardly tell if the patient is in free breathing or DIBH. So in this case, we developed a new criteria we call the vertical chest elevation. So if the clinically, if this value is less than 5 millimeter, and then we will go through different way to monitor patient to achieve DIBH. For instance, we create a new belly ROI, like shows here is a triangle shape on the belly, or we switch to the RPM or RGSC, which we used before now as a backup. And then this percentage, in our study, we studied 20 patients, actually 40 patients. The 6 of them go through we call the ADIBH, and then the remaining patient go through thoracic-driven DIBH. So this is consistent with the previous report. They have 27% patients go through ADIBH using their qualitative measure. And then even when patient goes through the so-called ADIBH, we still can achieve the heart sparing. And in fact, there are a couple of studies shows ADABH can achieve even more heart-sparing effects. However, at MSK, our belief is we try to preserve patients' native breathing behavior. If you change it through intensive coaching, and then likelihood that the patient will fall back to where their native behavior. So therefore, you might create more variation or uncertainty throughout the treatment. So therefore, our approach is online monitoring this patient to identify as early as SIM to tell this patient is go through ADABH or TDABH. So therefore, we can monitor them accordingly. And then this graph shows how the heart is spared. So basically, mostly it's come from the diaphragm pull inferiorly. So therefore, the heart shape will be elongated, and also heart position will move inferiorly. Part of the heart is out of the field. So that's how the heart sparing is achieved. It's a very different from TDABH. Okay, so another study we have conducted is we check the DABH, how useful this procedure for abdominal treatment. So we're using 40 CT. So because they provide both internal and external anatomy. And then we checked various position on the surface. And then the conclusion is if we draw the triangle shape away from the rib cage, the soft tissue part, which have most correlation with the internal diaphragm position. For instance, if you treat liver patient, and then you can have a very high correlation to tell where the diaphragm is going to be using this particular ROI. On the brain side, we just, like I said before, we just skip this process, go through directly to this. And then, of course, we gain a lot of benefit. Before we made a comparison study of around 200 some patients, and then compare LRT with the cone beam CT. The way we did this, right after you acquire cone beam, you acquire LRT. So the difference between these two imaging modalities is the difference in their accuracy for setup. And here this is a video I recorded in the first trial. We were worried about if the patient is too far away from the ICE center, and then the registration would not work because it's just too far away from where it should be. So we on purposely set the patient too far away, and then we found that this poster video feature is very useful. Regardless where the patient is, you can always see the difference between the actual patient position and then the destination position. And now I can show this. So at the beginning, you just using the posture video to guide you to move the patient. And then once you go close enough to the ISO center, you start to see the registration kick in. And from then on, you can using this actual shift to guide you to achieve the final LRT, sgrt setup. So this is, as I said, is the first trial. It only takes 25 seconds to complete this. And then later on, in patient, because they're not that far away from using the natural landmarks, so therefore they can achieve much faster than this. So overall, it's a very time-saving process. Now we're looking at the conventional 3D conformal treatment because this treatment doesn't have a daily 2D KV as the final setup. So we're trying to evaluate how well the LRT is going to be in the near future. And also there's another issue. So we're already started discussion with the physician to talk about it, because this currently sgrt billing is bundled with IGRT. So if we can proceed this for daily patient setup, how would we handle the reimbursement issues? Yeah, in the past, we have tried using LRT for various anatomic site. One of the, I think, most useful site is when we treat a very large field of view patient, and then if we do IGRT, they often require 2 imaging field views to cover the entire treatment field. For LRT, we can using, because they have a very large field, we can make sure that both part of the treatment site have a good enough alignment to begin with. So therefore, most likely, the 2D KV for both will be good enough. So therefore, they can reduce the imaging possibility. So we have tried with the green with the leg and the pelvis, so very large, and then the whole abdominal patient. And then another case we're trying is using high neck patients, so where we treat recurrence multiple lesions. So because the lesion is scattered around in the neck area, so if you treat with one single ISO, the control of the neck curvature is very important. Otherwise, you have to treat the lesion separately. The last is what we're right now using 3D printing bolus and also 3D milling immobilization device. So therefore, this sgrt procedure is very well fit in that clinical process. And we also proceed some clinical trial for setup for nasal cancer with the electron beams. Yeah, so here I show some other study across all other anatomic areas. So say like this is high neck, thoracic, and then CNS and the abdomen. So basically, you can see the same trend. The average similar accuracy is similar. However, the variation is much more reduced for SGRT. And then here is another study. Basically, they tell us pretty much the same thing. And also, they including the extremity in this study. By the way, this study is very trustworthy because they contain a very large patient pool. So therefore, statistically wise, it's very reliable. Yeah, so the remaining challenges. So we're, like I said, we're proceed this tattooless SGRT very cautiously. And so we're always conduct some clinical study before we implement. So therefore, we can avoid a lot of chaos in the clinic. As I said, we have 8 clinical centers. So if something wrong, because I'm in charge of all LRT operation, if anything wrong, then I will have a lot of nightmare there. Yeah, so also we're concerned about the opportunity beyond the anatomic alignment in the superficial area. So we're trying to using surface to tell what happened inside. So that's one of the study is showing the ROI for abdominal DABH. So I think surface imaging, of course, you can see everything outside, but there could be some opportunity we can tell what happened inside. And of course, motion monitoring and then the beating is also another issue we need to consider. Okay, so I'm summarized. So we have gone through some very early stage tattooless process. And right now, we're always have a confirmation from sgrt. And the benefit is reduced setup time, and then also have a very much similar accuracy. And then we have done this for both breast and then brain. And I already said we have some ongoing study to pursue more towards tattooless. Thank you very much.